Olá, boa tarde ou bom dia. Eu estou aqui em Hong Kong, no Congresso Internacional de Distúrbios do Movimento. Eu vou aproveitar para fazer aqui algumas perguntas, uma pequena entrevista com a Dra.Kathrin La Faver. Ela é neurologista, especialista em distúrbios do movimento e trabalha em Louisville e especialmente ela atua na área com distúrbios movimentos funcionais, distúrbios movimentos psicogênicos. Ela é alemã, mas trabalha nos Estados Unidos, vai falar inglês, depois eu vou tentar conseguir a legenda e ela vai explicar um pouquinho para nós o que é isto. Hi, Kathrin.
Hi, thanks for having me. Hola.
Thank you. So please, can you explain, first of all, can you introduce yourself?
Sure, yeah. So, Catherine La Faver, and I'm the director of the Movement Clinic in Louisville, Kentucky. I did my training at Mayo Clinic in Rochester, and I did a fellowship with Dr. Hallett at BNH, and that's where I became really interested in this topic.
Oh, great. Can you explain a little bit what it is functional movement disorders?
Right, so functional movement disorders, or some people also call them psychogenic or conversion disorders, are really mimicking other disorders, either tremor, gait problems, weakness, speech issues, that are not known due to a permanent structural issue with the nervous system, but really happen because of interruptions of voluntary movement control, and can often be triggered by a stress factor.
Okay.
The good thing is they're reversible. So it's actually very important to diagnose patients accurately and channel them to treatment that can help them.
Well, that's good. That's good. So, but you are saying that have some stressful triggers for that. But have any specific case that you already know, a cause that you already know?
So it's really not completely understood, and I think there's really a spectrum of patients presenting with these. So there's a higher likelihood for these disorders in women, and higher likelihood with history of abuse, sexual or physical abuse.
Okay.
But also physical triggers can cause it, and so it's not always the case that we do find abuse history.
Okay.
And so basically we think that really if there's a interruption of voluntary movement control.
But what is happened?
We don't know.
Okay.
I think it's really, we're just trying to understand what exactly triggers these things. But so we're kind of referring now to a biopsychosocial model for these disorders. There's probably some risk factors, even genetic risk factors,
Okay.
some environmental factors, early life experiences, etc., and then triggers that can start these disorders.
Okay. Okay. Great. So as being a functional or psychogenic, we don't like actually this word, right? But normally patients goes through a lot of psychiatrists and psychologists that many times they treat them. So what is the right approach to these patients? Like going to neurology, to the movement disorders, so how, or you treat like combining both therapies?
I think it's really important that the neurologist makes the diagnosis, because especially if they present with tremors, dystonic posture, psychiatrist is probably not the only person who should make the diagnosis. And just because it's a psychological stress factor is obviously not enough to justify this diagnosis.
Okay.
That's psychiatric comorbidities can be present in many neurologic patients. So neurologists, first of all, should make the diagnosis, and based on positive features, meaning based on features that are typical for functional disorders, for example, tremors that entrain or are distractible, myoclonus that is distractible, entrainable, or sometimes we can do electrophysiologic measures. And then the treatment approach depends a bit on the severity, whether or not there are psychiatric factors present or psychological factors present. And many patients respond very well to a combined approach with physical occupational therapy as well as psychotherapy and often cognitive behavioral psychotherapy. But I think it's important that people get treated by healthcare practitioners who are familiar with the concept of FND and have experience or know how to approach it, because physical therapy is quite different from standardized or
Physical therapy.
from sort of standard of care physical therapy, and there are specific treatment guidelines by Nielsen and others in the UK, for example, for physical therapy. So we know that some things work, but I think we need to spread the word to more practitioners on really how to help these patients.
Okay, that's good. And I know that you have this center that you get a hospital patients or for 1 day or 2 days. How works the treatment and how works the training that you do in your hospital? How it consists? How many professionals are involved? The treatment of this patient?
Yeah. So we have a monthly F&D clinic where we see people from throughout the United States for assessment. And if they need if they're more severely impacted, we offer a inpatient treatment program. So it runs over 1 week, and people come inpatient in a rehab hospital and get 3 hours per day physical occupational therapy and 1 hour psychotherapy. So it's a 1 week stay.
1 week. Okay. And after that, what the patient do? He returns normally follow up. What normally?
Usually they get guidelines on what exercises to continue. Sometimes continue psychotherapy at home. But a lot of times they are able to make quite remarkable progress in this short amount of time, and able to manage with not intensive ongoing treatment. So
That's good.
yeah.
It's very inspiring, this type of treatment, because we know how frustrating are those patients. And my last question will be, like, what do you recommend for those patients that have this diagnosis? And many times people say, oh, you're just nuts, you're just crazy, or everything that you are saying is not true, just happened because of your mind. So we know this is a real problem, and we know that we can help these patients now. So what do you recommend for those patients that have this diagnosis, or they're trying to have this diagnosis? What is your tip, or what is your recommendation for them?
So I think it's really, we all need to try to normalize this diagnosis more and realize this is extremely common. It really can happen in every age group, every gender, and just not treat it differently necessarily than we would approach someone with multiple sclerosis or Parkinson's disease, and explaining the diagnosis sort of in a way that people can understand and accept it, and showing them how they can get better. So currently there's really a huge stigma attached to the diagnosis, and people often feel very dismissed and basically told, well, this is or being accused of malingering, and it's very different. So I think we all can contribute in destigmatizing and helping patients.
Okay, good. I think it was perfect and really helpful, all your information. So thank you so much, and keep doing your great work.
Great.
With these
Yeah.
patients.
All right. Well, thank you.
Bye. Ciao,
Bye.
ciao.